You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi, everyone. This is John Mandrola from the heart.org Medscape Cardiology, and this is This Week in Cardiology for June 16th, 2023. This week, AFib screening, BNP, another new SGLT2 inhibitor, a Sky is Blue study, and one of the best trials of the year. Now, before I start, I want to say a word of thanks for the ratings and comments. TWIC podcast is up to 644 ratings on Apple Podcasts, and I've received a bunch of new comments this month, and I want to say thank you. I really appreciate the support. And of course, I also appreciate and learn from critical appraisal. I also want to thank the Einstein Cardiology Group in Philadelphia for inviting me to talk. I now have a new Grand Rounds lecture on contemporary critical appraisal of hot topics in AFib, including stroke prevention, AFib screening, early AF ablation, and even PFA. The new slide decks are always a good thing, so thank you. First topic today, AFib screening. The Loop trial investigators have published a provocative secondary analysis of their main trial in the journal Circulation. This study looking at the utility of using NT-proBNP as a potential marker for screening efficacy in regard to AFib yield and stroke prevention. Now, from now on, I'm just going to shorten NT-proBNP as simply BNP or natriuretic peptides. Before this secondary analysis, let's do a brief recap of the Loop trial, which randomized 6,000 patients, 1-3 fashion ILR versus standard of care. If AFib was detected with the ILR or in standard care, oral anticoagulation was started, and the primary efficacy endpoint was stroke or systemic embolism. And as you'd expect, there was more AFib detected, more anticoagulation used in the ILR group. However, the results in the ILR arm, stroke or systemic embolism was reduced by 20%, but it did not reach statistical significance, and major bleeding was increased in the ILR arm by 26%, and this too did not reach statistical significance. So this new secondary analysis, the idea is that the group with the higher natriuretic peptide levels must or might signal a group that was more apt to benefit from the earlier detection of AFib. But I have to say, treatment effect is very complicated, right? It's not a sure shot. Because remember the Andrew Foy picture that shows the 4 intersecting circles around treatment effect. So the opposite of a treatment-related benefit is treatment-related harm. So in this case, high BNP patients may have more benefit because they're higher risk from detecting AFib and then treating with oral anticoagulation. But opposing the benefit is harm, right? Higher risk people may have more oral anticoagulation-related bleeding. So again, benefit may be countered by harm. Now, also related to treatment effect is the risk of the primary outcome. That may be higher for AFib detected in patients with a high BNP, but the opposite here is at the rate of competing risks, right? A patient with a high BNP is going to be sicker. They may have other diseases that then compete with stroke, and any oral anticoagulation-related benefit may be countered by competing risks. So let's get into the study specifics. Now, most of the 6,000 patients in the Loop trial did have BNP levels drawn. The authors then separated out those with higher or lower than median levels. 2 groups, higher than median, lower than median. Now, having a BNP level above the median was associated with a higher risk of having AFib discovered in both groups, control and ILR. Those with higher than median levels of BNP also had a higher risk of clinical events compared with those with lower levels. Hazard ratios were like 1.21 for stroke and systemic embolism, 1.60 if you added CV death to stroke and systemic embolism, and almost double, 1.91 for all-cause death. All right, now for the key results. Compared with usual care, ILR screening was associated with a significant reduction in the primary endpoint of stroke and systemic embolism among those individuals who had above median BNP levels. The hazard ratio here was 0.60, so a 40% reduction, and the confidence intervals were significantly tight, 0.40 to 0.90. But in those individuals who had lower than median BNP levels, AF screening had no reduction in stroke or systemic embolism. Here, the hazard ratio was 1.11. So you have this subgroup, 0.60, 1.11, and they saw that same kind of trend if they used the endpoint stroke, systemic embolism, and CV death. And in both cases, the p-value for interactions were significant. Now, this may seem complicated, but think of a table 3 in almost any normal RCT. Table 3 usually shows subgroups. These are high versus low BNP is basically like a subgroup like male, female, diabetes, no diabetes, etc. The authors of this subgroup sub-analysis strengthened their paper by doing the analysis with BNP as a continuous variable, and here the strength of the AF screening efficacy increased with higher levels of BNP. And I may have missed this in the paper or the supplement, but they don't tell us about bleeding in relation to BNP levels, and I'd be interested in that. So my comments. Second author on the paper, Søren Didriksen from Copenhagen, had a nice thread on Twitter regarding the study, and I'll link to that. Søren made some interesting comments on Twitter, and he also asked a great question during one of the sessions I was at HRS. That is that he believes, and he may be right, that nearly every older person will have AFib diagnosed if they're screened enough. But these exploratory findings using natriuretic peptide may identify a group with a more clinically relevant phenotype of AFib if it's diagnosed. The first comment I'd say is I really like these efforts to try and extract as much information as possible from a trial, say the Loop trial. And a Loop group of authors have also published other super interesting findings from the study. First, I'll cite a paper from 2019. This paper was actually called by Eric Brostowski as one of the year's most important papers in 2019. It's published in JACC, and what they showed from this cohort from Loop was that more than half of short duration AFib becomes less burdensome with time, meaning the AFib goes down over time. And sit down for this, they found that 1 in 5 patients who have AFib detected on ILRs have no more AFib in follow-up. In other words, the AFib regresses. The Loop authors have also published a recent sub-analysis that found individuals in the ILR monitoring group compared with usual care had more bradycardia detected, more pacemakers implanted, and no decrease in syncope or sudden cardiac death. And this shows clearly that screening can cause overdiagnosis and overtreatment. So this BNP is yet another provocative subgroup analysis. And so it makes perfect sense that BNP could be a good marker, right? Because higher BNP has been associated with more AFib and worse outcomes. But I am very grateful for their caution expressed in the conclusion on the abstract. Quote, "These findings should be considered hypothesis generating and warrant further study before clinical implementation, period." End quote. Thank you. My friends, whenever you see a positive subgroup analysis, always remember the name Richard Peto, P-E-T-O. Dr. Peto famously did a subgroup analysis of the ISIS-2 trial of aspirin after MI and found that aspirin benefit correlated strongly with 2 astrological signs, clearly a spurious relationship. So the way to sort out using natriuretic peptides as a way to target AF screening is, you guessed it, an RCT. And turns out that the group of Emma Svenberg in Stockholm are planning Stroke Stop 2. And this will do a stepwise AFib screening based on BNP. So they're going to take an entire population of 75 to 76-year-old individuals, like tens of thousands, in the capital region of Sweden, and they're going to randomize 1-to-1 to an intervention or control group. And in the intervention group, the BNP levels will be analyzed in all who have no previously known AFib, and those with low BNP levels, they'll do a single 1-lead EKG recording, but patients with higher BNP levels, they'll do recorded ECG for 30 seconds at least twice daily for 2 weeks with a handheld ambulatory ECG monitoring, so more intensive monitoring. Now, these are really important efforts. The results of LOOP and Stroke Stop, plus the early termination for futility of the NOAA trial, you take these together, they show that generalized AFib screening is unlikely to deliver average benefit greater than harm, but focus screening may be more fruitful. And regarding the use of a nonspecific marker, such as a natriuretic peptide level, we must show that BNP is a good way to screen with outcomes, because we surely do not want to encourage the willy-nilly measuring of such a nonspecific marker because of downstream testing. And here I would point to, look what has happened with coronary artery calcium screening. There's tons of downstream testing, but downstream testing with BNP would make a coronary artery calcium screening look like a modest thing. The AFib screening community is doing things right. They are using trials. They're accepting the results of the trials. They're focusing efforts on those most likely to benefit from screening. The Journal of the American Heart Association has published an observational study that I am going to give a special award. It's called the Sky is Blue Award. The title of the paper, Physical Frailty and the Use of Guideline Recommended Drugs in Patients with Heart Failure with Reduced Ejection Fraction. This was a paper from a group in Japan who used a registry of patients who were admitted for acute heart failure. They then divided these 1,000 patients into 4 categories of frailty, measured by the usual parameters. They then recorded the rates of guideline-directed drugs, and you'll never guess what they found. The proportion of patients receiving all 3 drugs decreased as physical frailty increased. In adjusted analysis, frailty was an independent predictor of non-use of ACE, ARB, and beta blocker, but not MRAs. And what puts this study in the most obvious category, patients who used fewer drugs had worse prognosis in terms of all-cause death or heart failure hospitalization, regardless of the severity of physical frailty. Now, my comments. This is a great teaching paper. First point, as the authors write, deep in the discussion section, though, not in the abstract, is that the findings are associations in an observational study and likely confounded by selection bias. As I have said too many times to count in this podcast, when a clinician, not randomization, decides to use a therapy or not use a therapy, you cannot assess causation, because no matter the adjustments you make, you cannot match patients in all their characteristics. Of course, patients with frailty do worse and take fewer heart failure meds. The two are associated, but clearly not causal. So you ask, why even do these quasi-causal inference studies? And the answer is, I don't know. Bias in observational studies is not the main teaching point here, though. The main teaching point in this case centers on frailty as a marker of multi-morbidity. It should go without saying, but based on the comments from the heart failure community, I am not so sure. Comorbid conditions always affect a clinician's choice to use any intervention, including heart failure medications. So the movement to describe underuse of guideline-directed medical therapy in heart failure in the real world really bothers me. I, like you, take every opportunity to use full guideline-directed medical therapy in patients who can A, tolerate the drugs, B, afford to take the drugs, and C, have as their goal to take multiple drugs. The thing is, I'm not sure trialists and proponents know this. Many, if not most, patients with heart failure are dissimilar from those patients who are enrolled in clinical trials. I want to tell a quick story about a recent conversation I had with a research coordinator that highlights this difference. She was telling me that at her center, they are capped in their monthly enrollment for a new drug trial. The study involves a comparator drug with an already expensive drug. Patients who get enrolled in the trial get free drugs, so the research coordinator tells me that they are easily making their monthly enrollment, but she has to choose carefully who fits the study. I'm like, what does that mean? I ask. And she tells me that you should see some of the, quote, train wrecks that we get referred for this study. These patients have tons of problems, no transportation, no family. There's no way we can put them in a study. And that's my point. Take the heart failure studies. They're great studies, no criticism. But these were done in mostly stable outpatients. In Paradigm HF, the ARNI trial, for instance, had 2 run-in phases. There's no run-in phases in clinical practice. Trials enroll the best patients. Then they are treated with the help of research nurses. That's not like the real world. Frail patients with tennis balls on their walkers do not populate RCTs. Of course, patients with frailty are going to do worse, but their poorer prognosis is almost surely not related to non-use of ACE, ARB, or beta blockers. Instead, the frailty factors that influence physicians to not use ACE, ARB, and beta blockers are the factors that contribute to their worst prognosis. Guideline-directed heart failure therapy is wonderful. I am an advocate, but only in patients like those in the clinical trials, only in patients who can afford the meds, and only in patients whose goals of care aligns with taking that many medications. To me, this is doctoring 101. All right, third topic is Sotagliflozin, a new SGLT2 inhibitor. A few weeks ago, FDA approved this other SGLT2 inhibitor called Sotagliflozin. It's a once-daily tablet, and it's indicated to reduce the risk of cardiovascular death and heart failure hospitalizations in adults with heart failure or diabetes, CKD, and other cardiovascular risk factors. Sotagliflozin is special because it inhibits both sodium glucose cotransporter 2 and 1, and SGLT1 is prominent in the gut, and inhibition of it delays glucose absorption and reduces postprandial glucose levels. Now, Sotagliflozin passed FDA muster based on two regulatory trials, both published in New England in January. Both trials were cut short due to the loss of funding. The SCORED, SCORED, and SOLOIST, WHF trials are worth a few words briefly. SCORED planned to enroll 19,000 patients, but ended up randomizing 10,000 with type 2 diabetes, CKD, and risks for CV disease. These were 69-year-old patients, slightly less than half were female. The median eGFR of 44 milliliters per minute per 1.73 meters squared of body surface area. The primary endpoint was changed during the trial to the composite of total CV death, hospitalizations for heart failure, and urgent visits for heart failure. The PEP, primary efficacy endpoint, Sotagliflozin 5.6 versus placebo 7.5 per 100 patient years. Okay, that hazard ratio is 0.74, so a 26% reduction in the primary endpoint. Confidence intervals were tight at 0.63 to 0.88. So even though the trial did not enroll as many patients as they calculated they would need, the hazard ratio was clearly significantly reduced. Now, cardiovascular death was not different. Heart failure hospitalization and heart failure visits is what drove the endpoint. And there was more diarrhea, volume depletion, and mycotic infections in the Sotagliflozin arm. Okay, SOLOIST WHF, this was a heart failure trial. This randomized 1,200 patients who had diabetes and who had been recently hospitalized for heart failure. Also, these were 69-year-old patients, 1/3 female, and a mean ejection fraction of 35%, and 80% of enrolled patients had EF less than 50%. Primary endpoint was also CV death and heart failure visits. This trial was ended early due to a loss of funding, And I don't know the inside baseball on this funding issue. I'm sure some of you do, but I don't really think it matters based on the results. The PEP, primary efficacy endpoint, sotagliflozin versus placebo, 51 versus 76 per 100 patient years of the primary outcome. A hazard ratio there, 0.67, so a 33% reduction. And again, confidence intervals quite tight at 0.52 to 0.85. Now, CV death was actually 1.9% lower, but this did not get close to significance. Much lower rates of heart failure encounters drove the primary endpoint again. And also, again, hypotension, UTI, diarrhea were higher in the sotagliflozin arm, as was severe hypoglycemia, 5 times more common than in the placebo arm, but the rates were low, 1.5% versus 0.3%. So my comments on this new drug, the results from SCORED and SOLO-SWHF sort of strengthen the idea of a class effect from these drugs. And you expect that, just like there is a class effect with ACE inhibitors, ARBs, and surely beta blockers too. But heart failure expert Milton Pecker was not impressed. In our Heart.org Medscape Cardiology news article, he was quoted as saying, "There is no persuasive evidence that sotagliflozin has any advantage compared with SGLT2 inhibitors for the treatment of heart failure. Quote, I do not see why U.S. physicians might pivot from established SGLT2 inhibitors to sotagliflozin unless it was priced at a very meaningful discount to the other already approved drugs. Now, keep in mind also that sotagliflozin has not been shown to have any reduction in CKD progression, but primary author on both trials, Deepak Bhatt, was more optimistic. He pointed to a secondary analysis showing that sotagliflozin reduced a MACE endpoint, including MI and stroke. Now, I think that study was presented, but I'm not sure it's published yet. Plus, it's a subgroup analysis, right? Think Richard Peto. Sotagliflozin will not have an indication in diabetes either, so it will not see much use from diabetes specialists or nephrologists. It sounds like it's going to be mainly a cardiac drug. Now, I sort of come down in the middle on this. Empagliflozin and DAPA have had head starts. Clinicians are accustomed to using these drugs. They have more extensive data. And I also worry about the added diarrhea and low glucose levels seen with sotagliflozin, though it has not been compared head-to-head to EMPA or DAPA. Now, the company that makes sotagliflozin may price the drug lower to get it on the grid with doctors. That would help, but I doubt they will. Recall that dabigatran was the first non-warfarin anticoagulant. It had a substantial lead, but now apixaban and rivaroxaban have clearly won out in popularity. Now, the other thing that makes me wonder here is, and I'm asking this question to people who may know, what would have happened if sotagliflozin came first? It really makes me think about the super high stakes and speed of drug development. All right, I want to end on a really great note, a good note. The cardiothoracic community has given evidence-based medicine a huge boost this week. JAMA has published the UK Mini Mitral RCT comparing 2 ways to do mitral valve repair for MR. Now, even though the specifics here are surgical, there are huge, broader lessons regarding how we come to know things, and that is the sweet spot for TWIC podcast. Here is the backstory. The standard way to do mitral valve repair is with sternotomy. There's good exposure, and that's the way it's done. But technology and innovation has allowed a minimally invasive approach via a smaller lateral thoracotomy, which completely avoids sternotomy. And patients, it turns out, have been increasingly demanding that approach with the idea that anything less invasive is good. Also, cosmetically, there's no sternal scar. And observational studies and expert opinion have suggested that the minimally invasive approach leads to faster recovery, fewer complications, and less cost. But uptake of mini mitral valve surgeries have varied a lot per country. Now, I don't know about you, but this is an enticing first scene of a movie, right? We have a new procedure, a fancier procedure. We have strong proponents. We have marketing to patients, convincing them to desire the less invasive new procedure. And for the win, we have observational studies that are propensity matched even, showing positive results for the new procedure. What could go wrong? Grin. Enter medicine's ultimate test, right? The RCT. In the UK Mini Mitral trial, we have investigators randomized 330 patients in 10 centers in the UK to either standard sternotomy or the minithoracotomy procedure. The authors did something interesting. They sought out patient input to the choice of the primary endpoint, and they ended up choosing physical functioning and return to usual activities at 12 weeks. The quality of the mitral repair, the amount of MR, that was a secondary outcome. And death, repeat mitral surgery, and heart failure were safety outcomes. Now, at 12 weeks, the mean between group differences in the change in the physical functioning score was not different. Valve repair rates that were greater than 96% were similar in both groups. Echo demonstrated mitral regurg severity as none or mild for 92% of the participants, with no difference between groups. Safety outcomes, no difference. The authors concluded, quote, minithoracotomy is not superior to sternotomy and recovery of physical function at 12 weeks. Minithoracotomy achieves high rates and quality of valve repair and has similar safety outcomes at 1 year to sternotomy. Quote, the results provide evidence to inform shared decision-making and treatment guidelines. Comments, while I and likely you don't deal with a surgical decision regarding MR, I love this trial and its story. This is how interventions should be evaluated, right? You have all the elements of problems with non-RCT level evidence. You have observational studies showing favorable results with a new procedure. These are obviously biased because of patient selection. Surely healthier patients got referred to have the minithoracotomy. It also makes sense, right? It makes sense that minimally invasive approaches lead to faster recoveries. And you all know the lessons about things that make sense. Proponents of newer ways of approaching medical and surgical problems own the burden of proof. Plausibility, expert opinion, observational studies are not enough. Do what the UK Mini Mitral trialists did. Study it in RCT form. Congratulations to them from this podcast. Good job. So that's it for this week in cardiology. As always, I'm grateful that you listen. Thank you. And remember, those ratings, short reviews go a long way to helping others find us. Until next week, this is John Mandrola from theheart.org, Medscape Cardiology.
You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.